important things. And also I thank GSK for sponsoring these talks. It goes a long way. So my topic is recurrent and persistent pneumonias. This requires some attention and merit because it's deals with a subset of those cases which require little bit of a tailor-made investigations and an approach, so that we don't beat around the bush and keep wondering why it's happening again and again. So coming to this, coming to the definitions, pneumonia is basically infection. So we consider an episode of pneumonia as an infection. When there are two episodes of pneumonia happening in a time frame of 1 year, or more than 3 episodes in any time frame, with complete radiological and clinical clearing, we call it as recurrent pneumonia. But pneumonia generally should get recovered with appropriate treatment, say within 15 days or a month maximum. But if symptoms are persisting, or the radiological evidence of pneumonia is persisting beyond 4 weeks, some authorities even say up to 6 weeks, we call it as persistent pneumonia. So that's the main thing.
Is it symptoms and radiological changes? Or
yes, symptoms and radiological changes. Both. Clinical and radiological. So many times we miss because we may not do serial X-rays for a case of pneumonia which is improving, and we may also miss it also. So coming to the causes, so there are 4 important pathways through which these things happen. The first is some congenital malformations which may involve the upper airway. Say, for example, a cleft palate, or it could be a tracheomalacia or a tracheoesophageal fistula, particularly the H type of fistula, which leads to recurrent aspirations, or it could be some syndromes like P-Robin syndrome. That's one thing. And coming to the cardiovascular system, it could be any shunt which causes increased pulmonary blood flow. Typically, it's a left-right shunt, a large left-right shunt, or it could be a vascular ring which is causing obstruction on the airway. And some malformations in the lungs itself. It could be a lung cyst or a congenital cystadenoid malformation or a pulmonary sequestrations. These things can lead to recurrent or persistent pneumonias.
Now it's called PAM.
Yes.
Pulmonary.
CCAM. And there is another subset which involves recurrent aspiration syndromes, which may happen secondary to sometimes like malformations of the upper airway like cleft palate, or it could be some neurological or muscular disorder which leads to discoordination or incoordination between the swallowing and leads to recurrent aspirations. And even the common gastroesophageal reflux disease, if it's significant, can lead to recurrent aspiration. And foreign body inhalation itself is a type of aspiration which can lead to various types of puzzling pictures. And the third mechanism is the clearing of the secretions. So in this again there could be some which are primary causes or congenital causes. Common is cystic fibrosis, and another one is there is immotile cilia syndrome or Cartagena syndrome, where there is a primary dyskinesia of the cilia. Or it could be secondary to some infections. Some infections persist for a long time. Say it could be a pertussis, or it could be a measles, or even tuberculosis, which affects the clearing of the secretions, and this leads to a prolonged course of pneumonia leading to a persistent pneumonia. Or even obstruction of the airways in form of endobronchial or from an outer extrinsic obstruction, say a lymph node from a tubercular pathology, or some granuloma. They also can affect the clearing of the secretions and lead to recurrent or persistent pneumonias. And finally, as sir was mentioning, any problems with immunity. It could be a primary disorder of immunity, innate diseases of immunity, like X-linked Bruton's gamma globulinemia, or the host of diseases are there. Or it could be a secondary acquired immunodeficiency, commonly either HIV, or secondary to medications which suppress immunity, common being the glucocorticoids for used for some other cause, or immunosuppressives used for some other cause, can cause such symptoms. And the biggest culprit in our country is malnutrition with combination of certain infections, say measles or TB. They're all deadly combinations, and they lead to persistence or recurrence of symptoms again and again.
Inadequate treatment causes which type of?
Usually persistent, but if you are not doing proper serial X-rays, we may tell we may consider as recurrent, but by definition, it has to be clearing of the both clinical and the radiological clearing has to be there to call it as recurrent. Before going to these causes, there are certain diseases which cause symptoms of recurrence. We have a child with fever, coughs, showing fast breathing, but they may not be exactly fit into the definitions of recurrent pneumonias or persistent pneumonias. A few common things among them is undiagnosed asthma. A child has wheeze or comes with a viral respiration triggering a wheeze, and this happens again and again. X-ray may show clearing in between, symptoms may be okay. So we may think it as pneumonia, but we need a strong suspicion, and this accounts to most of the conditions where the symptoms are happening recurrently. And post-infective damage, particularly pertussis or some viral infections like RSV or atypical infections like Mycoplasma pneumoniae, they can cause prolonged and persistent symptoms. And finally, tuberculosis is one disease which can mimic anything. As we know, it can present with various presentations, and that has to be kept in mind before going into those 4 common pathways which I was mentioning. There are a host of other diseases which cause symptoms of recurrent respiratory system, which may be wrongly labeled as recurrent pneumonias, but they are not. Common among them is, as I already told, asthma is one thing. Any hypersensitivity pneumonia can happen again and again. Pulmonary hemosiderosis can lead to infiltrates. Whenever you do an X-ray, there is an infiltrate in one place. After some time, there could be an infiltrate in another place. Or sickle cell disease. This can lead to acute chest syndrome. So where there are episodes of chest infarcts causing symptoms like pneumonia, chest pain, and could be fever. And X-ray shows this thing infiltrate. Sarcoidosis is one more. Interstitial pneumonitis, alveolar proteinosis, eosinophilic pneumonia. These are the few things to name. Coming to the etiological agents, there is no specific etiological agent associated with recurrent or persistent pneumonias, but to name a few of them which are common. One is, as we know in developing countries, tuberculosis can cause persistent pneumonia, but sometimes treated or partially treated may recur after some time as a recurrent pneumonia also. Measles can cause a similar picture by different ways. It can reduce the immunity, so there could be a secondary bacterial infection happening due to some other cause. In immunocompetent people, RSV, adenovirus, CMV, chlamydia, these cases may take a long time. Adeno is known to take almost up to 1 year for the complete radiological resolution. And immunocompromised, the category of agents are entirely different. It could be pneumocystitis, Carani, Legionella, or some fungal infections. Here again, the approach is take a very good history, do a proper examination, that leads to the investigations to be done. So age of onset is important. So at the time of birth, if symptoms are developing, that mother tries to feed the child, immediately starts choking, then it ends up in pneumonia. It could be H fistula, or it could be H-shaped fistula, or it could be recurrent aspirations due to some incoordination in the swallowing mechanisms. Pneumonias due to immunocompromised states, particularly primary immunocompromised states, can happen around 4 to 6 months, not exactly at birth, little later. So that will give an idea whether it's congenital or acquired. And the details of episodes are also important. History about how the cough started. Was it a sudden onset of cough? It could be because of a foreign body which has been swallowed. Association with fever. Absence of fever or low-grade fever favors more of asthma or allergic the causes. And presence of other things like sputum expectoration and clinical examination pointing out to any consolidation or other things to point out to the area of pneumonias. Relation to the cough and feeding, which I mentioned, and relation to exercise. If there is exercise-induced worsening of symptoms, it could be something like asthma, exercise-induced asthma. History of past infections is very important. Sometimes, for our bad luck, it could be the first infection happening for a child with primary immunodeficiency. But if there are history of infections elsewhere, it could be a severe infection like septicemia, meningitis, or past pneumonias, or it could be some intraocular infections. I had a child which had one episode of orbital cellulitis, one episode of pneumonia, and had episodes of abscesses. Then came with complaints of drowsiness because mother thought she gave overdose of cetirizine. Turned out to be meningitis. But when we investigated, it was found to be C3 deficiency. So that history matters a lot. And past hospitalization, recurrent hospitalizations can happen in cystic fibrosis, in asthma, or such cases.
Throat examination gives you fluid tons, absent tonsils.
Absence of.
If you're looking at an X-ray,
Yes.
look for thymus shadow.
Yes, sir, yes. So in immunization, particularly if there is any disorders of cell-mediated immunity, if there was any reactions to live viral vaccines, it's an important pointer. Medications, history of glucocorticoids, or need to receive IVIG because of deficiency of immunoglobulins gives a indication towards a diagnosis. Perinatal history, was it a difficult labor, was it perinatal asphyxia, delayed cry leading to something like cerebral palsy, which is usually associated with aspirations if it is a very bad case of perinatal asphyxia. Cystic fibrosis can present with delayed passage of meconium, which could be an important clue. Even prolonged ventilation need for surfactant, even though nowadays with the advent of CPAP, we don't see cases of BPD, but it was seen in the past. And family history of wheeze, allergic rhinitis, they're all pointers towards the diagnosis of asthma. Family history of cystic fibrosis may be there. In some cases like X-linked gamma globulinemia, there could be a family history also. And again, developmental delay points out towards there is some underlying neurological cause, could be the cause of recurrent aspirations. Exposure to environmental toxins like pollutants, smoking at home, all these things indirectly affects the immunity of the child and cause recurrent episodes of pneumonia. Same things I've repeated here. Paroxysmal cough points towards foreign body or pertussis. Post-feed cough or frequent possetting can indicate GARD, or nocturnal cough following viral colds is something which happens typically with asthma. Requiring intubation prematurely, more towards BPD. Delayed meconium passage in cystic fibrosis. Persistent diarrhea, again so we should suspect pancreatic deficiency, which can happen in cystic fibrosis. Presence of multiple skin boils, multiple ear infections. Multiple ear infections particularly can happen in immotile cilia syndrome. Skin boils may indicate immunodeficiency. Continuous runny nose, presence of multiple grommets can indicate allergic rhinitis, and the cause could be something different. In the examination, we look at the anthropometry. Is the child thriving well? If the child is not thriving well, there is some amount of failure to thrive. Two possibilities strike. One is cystic fibrosis. Second one is a very large heart defect in the heart causing left to right shunt. So these two things, along with any neurological disorders, which in general affect the intake of the child, can cause failure to thrive. And even the growth parameters of the child and the development history also, as I mentioned, should be noted. Presence of clubbing can come in cystic fibrosis. Some cyanotic heart diseases, even though cyanotic heart disease per se generally doesn't cause increased pulmonary blood flow, but there could be some types which can cause increased pulmonary blood flow. Presence of generalized lymphadenopathy can favor HIV. In the ENT and face examination, look for any nasal polyps, which goes in favor of primary ciliary dyskinesia. Presence of telangiectasia can support a diagnosis of ataxia telangiectasia. Presence of cleft palate will be evident. And so, as told, examination of throat is very important. Look for lymph nodes. Absence of lymph nodes is a very vital clue for gamma globulinemia. Micrognathia, dysmorphisms in the, you can suspect syndromes like DiGeorge syndromes, where there can be cell-mediated immunity deficiency, and look for ear infection. And respiratory system, rule out asthma by looking for wheeze. Presence of stridor may indicate anything like vascular rings or extensive compression. Deformities may tell a long persisting airway disorder. Presence of dextrocardia definitely tells something like Cartagena syndrome, and murmurs is always significant in a case of recurrent pneumonia. So just in a diagrammatic way, look for nasal polyps, look for allergic salute or chronic rhinitis, perforated eardrums. In the chest, look for dextrocardia, heart murmurs, digital clubbing for bronchiectasis, as in cystic fibrosis or cyanotic heart disease. So the diagnostic approach, as I said, is based on the very careful and thorough history and a proper examination, which tells which pathway we have to investigate. Few things to rule out is asthma, TB, and congenital heart disease. Once these things are ruled out, we should always have a sequential radiograph to call it as a persistent or a recurrent pneumonia. Finally, based on our symptomatology and the examination findings, the investigations is tailor-made. So there is another approach if we are seeing the shadows or recurrent pneumonia in one lobe versus multiple lobes. If it is a single lobe, it favors something like a malformation of the lungs, like a CCAM or a pulmonary sequestration, lung cyst, or even foreign body which is stuck at a place, and if it is not removed, it can lead to bronchiectasis. Another thing is recurrent aspirations tend to go towards the right lower lobe. That's one thing to be kept in mind. If it's a multi-lobar disease, probably it's a more generalized disease. Commonly we should think about recurrent aspirations, generalized defect in immune response, or widespread mucociliary dysfunction. So the diagnostic approach for this is, if it's a unilobar disease, you're suspecting few congenital malformations or a foreign body. There is a high suspicion of foreign body. It's always better to get a flexible bronchoscopy. One thing we can rule out is a foreign body. Apart from that, if there is any extrinsic compression, there can be an indication during bronchoscopy, or presence of any bronchial adenomas or tubercular growths can be made out. That is normal. Second step would be to get a CT. So that is to identify any extraluminal obstructions or any congenital malformations of the lungs. But if based on the localized disease, if it's a narrow airways, if it's an extrinsic obstruction, it is either lymph nodes, neoplasms, or vascular rings. If it's a bronchial wall which is involved, it could be bronchomalacia or some stricture. If it is an endobronchial block, it could be, as I told, inhaled foreign body or TB calcification or some neoplasm. And if it's a congenital lung lesion, I've already mentioned that. Suppose it's a multilobar disease happening widespread. So first, does our history indicate, is it a primary immunodeficiency? If we feel it's normal immunity, rule out the causes like aspiration, GRD, etc., or allergy or asthma, or rule out mucociliary deficiencies, or post-infective diseases, particularly TB, pertussis, etc., or any structural abnormalities, or it's a left-right shunt. But if there is history which is pointing towards some problem with immunity, we can go ahead and get the next level of investigations to rule out immunodeficiency. So this is a tiered pyramidal approach for the managing or investigating a case of recurrent pneumonia. Baseline, will always get a chest X-ray to make sure it's a recurrent or persistent disease. Tuberculin skin test can be done. A CBC will give a clue. The lymphocytes are deficient, that can give an indication that could be some deficiency in the immunity. Next step would be either if the aspiration is suspected, you can do some esophageal manometry or barium swallow studies. And if asthma is suspected, you can see the response to the inhaled bronchodilators, or always get help of Dr. Manjunath Sharma. And if immunity is suspected, you can get a CBC, quantitative assay of the immunoglobulins. The final level would be the other things like flexible bronchoscopy, high resolution CT, and studies to look at the function of the ciliary motility. Even nitro blue tetrazzolium test can be done to rule out the neutrophil adhesion defects. So management principles.
CGD.
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 Management principles is always depending on the underlying cause. So the first step is to treat the present infection, as Dr. Shashidhar has told us very well. Once the underlying cause is treated, once the pneumonia is treated, we should look into the underlying cause and try to address that. And supportive care is always important in form of nutrition, avoiding smoke and pollutants. And finally, based on the cause, specific therapy like treat the asthma or treat tuberculosis or treatment of cystic fibrosis symptomatically can be done, or GERD. So key takeaways are persistent and recurrent pneumonias often due to host defects or defense or anomalies. Common causes, 4 things are aspirations, congenital malformations, ciliary immotility, and immunodeficiencies. History and examination gives very vital clues. Imaging, bronchoscopy, sweat test, immunology are the key tools. So these are my references. I've taken help of Notebook LM and Copilot to make the slides. Thank you. Any further questions?
So does that mean every pneumonia has to be checked for radiological resolution?
Not necessarily. Suppose there is a history of a second set of symptoms, then probably we may have to.
It's a typical garden variety community acquired pneumonia. There is no need to do the
Yes.
If there is a non-resolution or if it's a worsening, yes.
Yeah. So the cases which are requiring hospitalization and possibly a little extra with respect to management would always go home with a normal X-ray, or
Not
like
necessarily.
an X-ray
Not
again to
necessarily.
check?
Not necessarily.
Not
But of course, if the child had an empyema or things like that, they would be doing a repeat X-ray.
Okay.
They make sure now that the empyema is resolved. And if there's an underlying collapse consolidation and all this, maybe they would do a repeat X-ray. You know that at the end of 3 to 4 weeks only, not earlier than that. Because there may be clinical resolution first, then the radiological resolution.
That
It
is
takes a
true.
longer
So
time.
I was just trying to fit in this definition of recurrent pneumonias, where we say that both have to be the
Yes,
second episode happening
Recurrent
within.
pneumonia, there should be a complete resolution between 2 episodes.
Right.
If he gets one pneumonia in June, the second one pneumonia in the month of September, October, in between the child should be clinically normal and radiologically normal.
Exactly. So how do we know that the radiological clearance has happened unless we have done an X-ray?
Correct.
Now
That's
here
the
you have to
question.
then look at what is the cost benefit ratio of doing a second X-ray for every pneumonia.
Right.
Versus how many are going to pick up doing this procedure. I think definitely the recommendations hold that there is no need
There's
for
no need.
radiological confirmation.
Right.
If it occurs a second time, then you
Then we
investigate.
Right.
Thank you.